Hello, and welcome to today's webinar, Preparing for the 2021-2022 Flu Season, What to Expect and How to Plan. My name is Robin Mosen, and I'm a Senior Program Analyst with the Immunization Team at the National Association of County and City Health Officials, and I will be moderating our session today. I'd like to start by thanking you all for joining us and for the work that you and your colleagues are doing across the country during this pandemic. Today's webinar is sponsored by the NACCHO Bronze Affiliate Partner, ChemBio Diagnostics, and will focus on the importance of early detection and response to curb the spread of infectious diseases. While we know that local health departments are on the front lines in providing influenza education and outreach, administering influenza vaccinations, and coordinating resources to prepare for the threat of a pandemic influenza emergency, experts have indicated that the 2021-2022 flu and respiratory season will be unpredictable. Today, our presenters will discuss why it's more important now than ever to be prepared for the upcoming flu season, including the impacts of COVID-19. Please see here the agenda and the breakdown of our time together today. After the presentations, we will be opening the floor for questions and discussion. Before we begin, just a few friendly reminders. During this presentation, all participants are in listen-only mode. Please feel free to submit questions or comments via the Q&A box at any time during the webinar, and we'll respond to those during the discussion session. As mentioned, we'll have the discussion and Q&A following all the presentations. And finally, this webinar is being recorded and resources will be available shortly after we end today. They'll be sent out to all registrants via email and posted to virtual communities. And now it is my pleasure to welcome today's presenters. First, we have Dr. Lauren Ancel Meyers. She is the Cooley Centennial Professor in Biology and Statistics at the University of Texas at Austin. For over 20 years, Dr. Meyers has pioneered the application of network theory and machine learning to improve the detection, forecasting, and control of emerging viral threats. She is the founding director of the UT COVID-19 Modeling Consortium, which has provided global leadership throughout the pandemic through COVID-19 forecasting dashboards and critical analyses to support pandemic surveillance, response, testing, and school opening strategies nationwide. Dr. Meyers received her BA in Mathematics and Philosophy at Harvard University and her PhD in Biology from Stanford University. She was named as one of the top 100 global innovators under age 35 by the MIT Technology Review in 2004 and received the Joseph Lieberman Award for significant contributions to science in 2017. Our second presenter today is Dr. Aubree Gordon. She is an associate professor of epidemiology at the University of Michigan School of Public Health. Dr. Gordon is a world leader in influenza epidemiology, focused on the dynamics of viral transmission and development of immunity to respiratory viruses. An NAS Kavli Fellow, Gordon's epidemiological studies have helped provide the data needed to optimize the timing of vaccination in Nicaragua, as well as identified novel immunological findings that impact the design and testing of next-generation influenza vaccines. She rapidly shifted her focus to include the study of COVID-19 at the beginning of the pandemic and multiple field studies of SARS-CoV-2 to examine the natural history and transmission of the virus. Thank you both for being here, and now I will hand it over to Dr. Meyers to begin her presentation.
Thank you so much, Robin, and thank you all for being here today and for your service to your communities and our nation throughout this crisis. Although I will not be talking about COVID very much today, that is really where we've been focusing a lot of our efforts in building models to forecast and support decision-making at like the local, state, national scale. And I would certainly welcome the chance to discuss with you some of those activities and ways in which we could support you outside of the context of this presentation. But today, Dr. Gordon and I are gonna focus on thinking ahead to what might be in store for us in the very immediate future in the 2021-2022 flu season. And I'm gonna come at it from sort of a high level epidemiological population perspective. And Dr. Gordon is going to sort of get more into the weeds as you will hear now. So go ahead and advance the slide. Or do I do it myself? Okay. So as you all know, and probably have dealt with on the front lines, every year, most years, seasonal flu exacts a significant burden in our populations in the United States. A typical year, there are over 30 million infections, leading to tens of thousands of deaths and hundreds of thousands of hospitalizations. And many of our healthcare systems, our hospitals, are equipped so that they can just barely manage the surge at the peak of flu season. So that is a time of year, especially during moderate or large flu seasons, that really puts our healthcare systems under strain. Around the globe, typically there are 3 to 5 million severe cases of influenza each year, leading to hundreds of thousands of deaths. So next slide, please. So this is as a modeler and somebody who works quite a bit on trying to use mathematics to explain the drivers of outbreaks and to forecast outbreaks. I look at graphs like this all the time. And these kinds of graphs have become very familiar, I think, to the general public and to almost everyone in COVID. These are called time series graphs or epidemic curves, and they show us sort of the activity through time. So this is a time series graph showing our sort of the annual flu outbreaks. So starting on the far left, that's the 1997-98 flu season that peaked in February, and then the next flu season peaked in February, the next one in December. And you can see in most years, our flu season peaks somewhere between December and February, sometimes March. And the height of the peak, the severity of the season, how much it sort of taxes our healthcare systems varies from year to year. The red portion of the curve corresponds to the 2009 H1N1 pandemic that emerged in the summer of 2009. It had a small surge in the summer, and then a very large, very early wave in October of 2009. And then following that, we went back to sort of our usual routine of annual outbreaks that peaked sometime in the winter. I've highlighted in orange the most severe flu season on recent record, the 2017-2018 flu season, which led to an estimated over 60,000 deaths in the United States. So when we talk about seasonal flu, we're not talking about one virus, but we're talking about a constellation of viruses. There are 3 major types, A, B, and C, and there's diversity within each one of these types. There are 2 widely circulating subtypes of A. There's the H1N1, the H3N2, and then 2 lineages that widely circulate of B. And within each of these types or lineages, there is quite a bit of diversity and ongoing evolution. Next slide. So for example, this is a phylogenetic tree showing the evolutionary relationships between different viruses that have been isolated. All of these are H3N2. Going from left to right, we're seeing evolution through time. The points on the far right side of this correspond to single isolates that have been taken from flu patients over the last couple of years. Go ahead and advance. And you can see last flu season leading into the 2019-20 flu season, there was quite a bit of diversity. Each of those colors corresponds to sort of antigenically different clades that look different from the perspective of the immune system, look different from the perspective of what you'd put in the vaccine. And if you fast forward now, advance the slide to where we are today, go back one, to where we are today, you'll see in that last little sliver, it looks like there's a little bit less diversity of recently circulating strains relative to what we saw in 2019-20. However, that may be due to our undersampling as we've been very much focused on COVID and haven't seen a lot of flu, as we'll get to in a few minutes. Okay, you can advance the slide. So in any given year, we will have a sort of different combination of A, B, and C viruses that are circulating. So looking at this time series graph back in the 2006-2007 flu season, you can see in this little pie chart that over half of the cases that were characterized were H1N1, and then the remaining half were made up of B and H3N2. The next season looks slightly different. It flipped to being dominated by H3N2. And then in 2009, the next season was sort of flipped back. And then in 2009, a new H1N1, now denoted in red, swept through. It was essentially the only flu that was spreading that year. That was the pandemic. And it completely replaced the previously circulating yellow H1N1. And since then, our seasonal outbreaks have been caused by various combinations of descendants of that pandemic H1N1, H3N2, and the different B lineages. Next slide, please. So as somebody who is sort of in the business of trying to understand the drivers of these patterns, and importantly to forecast what's in store, we have a lot of different forecasting goals. In the immediate future, we are always trying to anticipate what's just about to happen. And that's really the focus of today's discussion. What's about to happen in the coming flu season? We want to know when the flu season is going to start. We want to know when it's going to peak. And we want to know its severity. How high is that peak going to be? How much is it going to stress our hospital systems? What can we expect in terms of mortality? Longer term, we are always looking a season ahead to try to anticipate which of the subtypes and lineages are likely to be circulating. And we have to make those projections in advance. We have about a 6 to 9 month lag between making the decision about what specific viruses are going to go into the flu shot and actually administering those flu shots. And so we're looking at data from around the world, trying to anticipate where things are headed in the following 9 months. We also try to anticipate when and where future pandemics might emerge. A lot of our pandemic preparedness leading up to the COVID pandemic assumed that the next global pandemic would be an influenza pandemic. And so there's been a lot of effort put towards trying to anticipate what parts of the world, what times of the year, what sort of settings are prone to the emergence of novel threatening variants. And then finally, at the end of the day, all of our efforts to forecast what's about to happen in the near or the long-term future are really about mitigation. We want these forecasts to provide information that leads to public health professionals, to policymakers making decisions, amassing resources, making plans so that we avoid catastrophic pandemics, that we mitigate the impacts of seasonal and pandemic flu. Next slide, please. So prior to COVID, our arsenal for fighting flu it consisted of about 3 or 4 different weapons. First and foremost, of course, we have the flu vaccine that we try to administer to as many people as possible on an annual basis. But it's not a silver bullet. Next slide, please. These are estimates of vaccine effectiveness over about 15 years, I believe. And vaccine effectiveness has been as low as 10% in some years and as high as 60% in other years. Next slide, please. And we also see that uptake varies through time in terms of the proportion of children and the proportion of adults who are vaccinated. As you look to the right part of this graph, you see sort of a promising trend, an increase in uptake among adults of the flu vaccine. Next slide, please. So in addition to the flu vaccine, of course, we have other non-pharmaceutical measures in our arsenal, washing hands and hygienic precautions to prevent the spread of flu. In some serious cases, when we have large outbreaks, we will even close schools to try to mitigate transmission to stop outbreaks. And importantly for flu, but not really for COVID yet, we have some effective antiviral drugs that can help to reduce the symptomatic period and reduce the chances of hospitalization and severe outcomes. And the most well-known of these drugs is Tamiflu, which has been widely used for many years and has been stockpiled for future pandemics. But recently, in 2019, we had a new drug introduced to market, which is known as Xofluza or Baloxavir. And this, unlike Tamiflu in clinical trials, has been shown to very rapidly prevent viral replication in the host, to very rapidly reduce viral load. And the study that's shown here on the bottom of your screen is a study that my group did just before the COVID-19 pandemic that shows that if we can really ramp up the use of these fast-acting drugs like Baloxavir on a population scale, we not only can reduce the burden of illness, but we can actually prevent transmission by shortening the infectious period of people who receive the drug shortly after infection. Next slide, please. So COVID has added some possible weapons to our arsenal. Importantly, the use of face masks and other sorts of social distancing measures, which has been our primary mode of combating COVID, have proved to be useful for flu as well. So this is a graph from Scientific American showing a bunch of different flu seasons in the Southern Hemisphere. And then that orange line you see along the bottom was the 2020-2021 flu season. So our interventions against COVID, our non-pharmaceutical measures, our shutting down of schools and staying home, succeeded in essentially quashing the spread of flu throughout the 2020-21 winter season, both in the Southern Hemisphere, as we saw first, and the graphs of the Northern Hemisphere look just like this. So these new social distancing measures can actually be quite effective, although, as we know, they're hugely socio and economically costly if taken to the extreme. Next slide. So in addition, one of the most effective yet underutilized strategies for controlling COVID, which also could be used quite effectively in controlling influenza, is mass testing during peak times of transmission. And that means not just testing symptomatic people or people who've been exposed, but actually proactively testing everybody who goes into a school or everybody who goes in a workplace, with the idea being that if you test people on a regular basis, you will catch people even before they develop symptoms during that sort of silent infectious period. And the study that you see on the bottom is one by my group, but there have been many others, similar studies showing that it is cost effective, it is beneficial to be testing people proactively on a weekly basis in schools, in workplaces, in communities as a safeguard that allows people to get together in person, even when the virus is spreading widely. And we can deploy a very similar approach against influenza. And in the immediate season, when we expect that we may see both COVID and influenza circulating, regular testing for both COVID and for flu is going to be really important in mitigating transmission and just navigating the uncertainty that lies ahead. Next slide, please. A final recent addition to our toolkit is the use of staged alert systems. So in Austin, Texas, where I live, like in many cities, not only across the United States, but across the entire globe, government agencies, public health agencies have enacted clear systems for changing policies, for enacting stay home measures, for relaxing those, for enacting face masking and other sorts of measures, changing occupancy in restaurants. And this has become sort of commonplace. And in many communities, the public has gotten used to tracking different key indicators, different data sources, and changing behavior as the risks increase and the risks decrease. And this is, while we know we've heard of alert systems for terrorism, for weather, it's becoming commonplace now to think about these for infectious disease outbreaks. And this may be something that becomes the norm for navigating future flu and or COVID seasons as we go ahead. Next slide, please. So what can we expect in the coming flu season? Well, a widely discussed hypothesis that my colleague, Dr. Gordon, will dive much deeper into is that because we didn't have much of any flu last season, we have less immunity built up in our population than we usually do going into a flu season. We have greater levels of susceptibility to flu because we didn't have a large season last year. We didn't have many people infected. So because of that higher level of susceptibility, we may see a larger than normal flu season. But is this a guarantee? No. I mean, if you look back in history, I've put an arrow there over a flu season that looks relatively small. That was followed by another relatively small flu season. And now the second arrow I'm going to show you is that really very large and severe 2017-18 season. That followed a moderate season. It wasn't a particularly small season the season before. So it's not a perfect predictor, but as you'll hear in a minute, we are seriously concerned about the level of susceptibility in the population right now. Next slide, please. Also, in the more pessimistic sort of side of things, kids are going back to school as we speak in a way that is much less sort of cautious than it was last year. In some places like Texas, we can't even enforce face masks in school. We're really not giving much of an online option. And we know that kids are sort of the leading wave of transmission in communities for influenza in a typical flu season. So their return to school as we speak will very likely amplify the spread of flu in a way that it did not last year. And then on the positive side, there may be some things working in our favor to reduce the risk of a very severe flu season. One is that, as I showed you earlier, there seems to be lower genetic diversity among currently circulating influenza viruses. Maybe that indicates that we're more likely to have a good match to the current vaccines that are available, but that's uncertain. Also in the sort of more optimistic camp, next slide, please, is that we've seen recently vaccination rates for influenza increasing among adults. And I think with all the attention to COVID vaccines, we may even see higher levels of vaccination against influenza this year, which would certainly be positive. And then the use of face masks, social distancing, other non-pharmaceutical interventions, including proactive testing during surges, may become commonplace and a tool that we begin to use to mitigate influenza when it starts to really pick up in our communities. So on my final slide is just to say, regardless of whether it is a large season, a moderate season, or a mild season, even if it is a mild season, we need to be concerned about the integrity of our healthcare system. Overlapping waves of COVID-19 and influenza, even modest influenza seasons, will stress our healthcare systems, which are really designed to barely deal with the typical influenza surge. So with that in mind, it's important not only for our own health, but for the integrity of our healthcare systems, the safety of our communities, to do everything we can to deploy our usual and our new arsenal of strategies for mitigating influenza in the months ahead. So thank you very much, and I'm delighted to hand it over to Dr. Gordon.
Thank you, Dr. Meyers. Now we'll hear from Dr. Gordon. Go ahead. Thank you.
I was going to say thank you, Dr. Meyers, for that great talk, and thank you, Robin, for the nice introduction. So I'm going to be talking today a little bit about why I think and why many scientists think that this influenza season will be particularly bad. Next slide, please. So I won't repeat what's already been said here, but one thing I did want to point out is, and important for this talk, is to talk about the surface proteins of influenza. As you already heard, we've got two subtypes of influenza, A, H3N2, and H1N1 PDM. And we've also got another type of influenza, influenza B. Those are the ones that cause epidemics in humans. And these glycoproteins, the kind of colored in yellow or light yellow here on the surface of this virus, are really important because those are the primary targets of our immune system, also the primary target of the influenza vaccine. And so when we get vaccinated or we get infected, we generate antibodies both to the internal proteins, but predominantly to these external proteins. And in spite of that immunity that arises, we get reinfected. In fact, most people have been infected with influenza many times in their life. Next slide, please. So why do we care about flu? We've already heard a lot about that from Dr. Meyers, but just there's an incredibly large burden of disease with many people getting sick. Globally, it causes many deaths per year. It's estimated at between 290 and 650,000 deaths a year by the WHO. And of course, there is a huge burden, particularly in vulnerable populations, so both in infants and children and the elderly. And there are some real limitations in the preventative measures that we have available. Next slide, please. So what did we see in this last year? As you probably are aware, and certainly Dr. Meyers covered, there was this dramatic reduction in influenza. So here, this is showing influenza activity in the United States from 2017 through 2021. And what you can see is that each year we had a very predictable or fairly predictable peak of influenza. They varied in size. But in 2021, there was really almost the 2020-2021 season, there was almost no influenza, both in the United States and globally. Next slide. So the question emerges, does missing a season mean we'll have twice as many cases the following season? Next slide. So to think about that, we have to think about how infectious disease transmission emerges. And this comes from a paper by Neil Ferguson, who is a modeler in the United Kingdom that was published in 2003. So here we have each dot representing a person So the blue dots represent susceptible individuals, the red dots represent infected individuals, and the green dots represent recovered individuals. So basically you're susceptible, you get infected, then you recover. For some diseases, you recover and you have immunity for life. For flu and for SARS-CoV-2, you recover, you don't have immunity for life, and you can eventually get reinfected. So we have a population starting here at this time point 1, where 1 infected individual is introduced into the population. At the second time point, then that person infects 2 people, right? And so we've now got 2 infected people, that person recovers. The third time point, we now have 4 infected people, and then it goes on. Here at the fourth time point, we have 8 infected people. So this is an example of a disease where each case leads to 2 new cases in the population. So you've probably heard the term R0, or the reproductive number. So this would be a disease with a reproductive number of 2. And this is really kind of a simplified version of this is what happens in a small population with no pre-existing immunity, where you can get a disease once. And there are a lot of other assumptions that go into it. And we'll talk about a little bit about why some of these might be a little bit more complicated. Next slide, please. So here we have an epidemic curve, or actually 2 epidemic curves. So it's just showing the incidence of infections over time. And if you kind of follow this, the red line there, we've got a curve, right? It reaches a peak. Going up that curve, that's when you're going to see a reproduction number, or an R0, that is more than 1. And then you've got this downside of the curve that's really shaped by the exhaustion of susceptibles, of people running out of immunity. Now, the shape of the curve and the size of the curve, the area under the curve, is really determined in large part by the number of susceptibles in a population. So here we have another example with this blue curve, where you can imagine there were fewer susceptibles in the population, so you reach peak earlier, and the total area under the curve, the size of the epidemic, is less because there were fewer people that could get the disease. Next slide, please. Of course, real life isn't quite that simple, right? We were kind of talking about the situation here on top. Each dot is representing a person, right? So we've got a disease with an R0 of 4. So each person is giving the disease to 4 additional people, right? And it just kind of goes on and spread. But with diseases like influenza, we have pre-existing immunity, right? So not everybody in the population is going to be susceptible to the disease. And that's what we've got in part B down here, which is from a paper from Fine et al. And so here we can see that although each person could theoretically give the disease onto 4 individuals, because 3/4 of the population has immunity, on average, they're only giving they're only passing this disease on to 1 additional person. So this would be an effective reproductive number of 1, because each case gives to 1 additional person. And here, that's where you wouldn't see an epidemic curve, right? It would be kind of a flat line transmission. So transmission isn't stopping, but it's not increasing either. Next slide, please. So for missing a season, right, we know that we're going to see an increase in the number of susceptible individuals for the following season. That's because there are people who didn't get it the prior season who would have had it circulated. There are also new individuals that are being introduced into the population because we have babies that are being born. But it may also affect transmission dynamics, right? Because as susceptibility in the population increases, as immunity decreases, that is going to change how the disease transmits. And I think it's going to likely lead to a higher number of cases in the following season. Next slide, please. So that's just kind of talking about the number of infections really overall, right? But are there other factors that might result from missing a season that might affect the severity of the next influenza season? Next slide. Well, to think about that, we have to really think about why people get reinfected. And I think, the 2 main reasons that people get reinfected with influenza are antigenic drift and waning immunity. And I will talk about each of those. Next slide. So we've already heard a little bit about antigenic drift from Dr. Meyers. And so this is really genetic changes that happen in the virus. Specifically, what we're looking at are antigenic sites. Those are sites that antibodies identify on the virus that protect you from the virus. So you've got these small changes that change the way the virus appears to our immune systems and helps the virus to really evade the immune system. So you get these changes over time. Over here, we've got an antigenic map kind of starting up in the top right, Hong Kong 68. You can kind of see each of these are years following through time. So the virus is changing how it looks, and that's allowing it to evade the immune system, either by making pre-existing antibodies less effective or sometimes by making them not effective at all. Next slide, please. So why do we care about antibodies? I'm sure, I feel like many people, even my fourth grader, can now talk to you a little bit about antibodies after SARS-CoV-2. But we care about antibodies, right, because they protect us not only from infection, they also protect us from disease. So on the left side here, we've got a chart. We're looking at the infection percent by serum antibody level before challenge. So this is a human challenge study where they take individuals, and this was in 1972, purposely expose them to influenza. Then this would have been age 3 and 2, and then they see who develops disease. And what you see is that, or who gets infected, sorry, what you see as that serum antibody titers increase, this is specifically antibodies to the hemagglutinin head, the percent of individuals that get infected decreases. More recently, here's a paper from 2009 looking at H1N1 PDM, kind of the same concept though. What we see is as we see an increase in antibodies to kind of any of the surface glycoproteins, then we see a decrease in the probability of individuals being infected. Next slide. So antibodies are going to protect you from influenza infection and disease, right? But the problem is that antibodies wane over time. And we've known that for a really long time for influenza, for other diseases. So on the left side, we've got a paper from 1941. So this would be the old version of H1N1 that was circulating at the time, looking at individuals over a year time after being infected. What you can see is during infection, they get the sudden jump in the antibody levels, and that really wanes over time. On the right side, same thing, a little bit over a year period of time with H1N1 PDM, showing that regardless of whether or not you are symptomatic, you get that initial rise in antibody titers, which then wane relatively rapidly over about a year time period. Next slide, please. So we've got the virus is changing, right, which is allowing, and that's happening over time, allowing the virus to, potentially evade your pre-existing immunity. We've also got pre-existing immunity waning. So how does that combine? So here we have from a study in my group that we've done looking at children aged 0 to 14. So this is an observational study. We're just seeing if children get infected and then kind of watching them march forward in time and see what happens in the future. And what we've done here is we've taken a group of kids and kind of, for example, if we look at the season 2015 to 2018, we would take children who were infected in 2015 and we follow them forward, look at what happens in 2018. What's their odds of getting influenza in that year? And then we take a group of children who were not infected in 2015, and we follow them forward to 2018, and we see what is their odds of being infected in 2018. We then take a ratio of those odds, so the odds of the infected to the odds of the non-infected in the first season, and we get an odds ratio. And so an odds ratio of 1 would mean that infection doesn't provide any protection against future infection. An odds ratio of less than 1 means that it's protective, and an odds ratio of greater than 1 means that infection would actually put you at risk for subsequent infection. And what you can say here, kind of starting on the right-hand side, going from the top to the bottom, we're comparing flu seasons. So 2011 to 2013, 2013 to 2015, 2015 to 2018, etc. As you go down that graph, the time period that's being compared is increasing. So we've got 1 year, 2 years, 3 years, 4 years, 5 years, and then 7 years. It's determined by when the virus circulated in Nicaragua. And you can see that on the shorter time periods, there's significant protection from reinfection that is seen. But over time, as we get to 5 years and 7 years, that prior infection is no longer protective anymore. And so really that's a combination of, right, the virus changing over time and the antibodies waning. I'm not going to show you H3 and 2 right now, but what I can tell you is that virus changes a lot more rapidly. So we tend to only see protection from reinfection for about a 1 to 3 year period, depending on how much the virus has changed over that time. Next slide, please. All right, so we know antibodies protect you from infection. We know the virus is changing over time, but do antibodies do more than just protect you from infection? So to think about that, to talk about that, we need to talk about the spectrum of disease of influenza. And so people usually often show this as an iceberg. I've done the same thing, right? Where we've got this tip of the disease, which is really severe disease. So this is hospitalizations and death. Then you have clinically attended disease. So these are people who come in, see a physician, get testing. And then you've got the rest of the iceberg, right? Mild disease where they haven't come in for treatment or testing, and then subclinical or asymptomatic disease where they might not even realize that they are infected. And there are a number of things that determine how sick you get when you get infected: your age, pre-existing immunity, comorbidities, and probably the exposure dose and route, as we've seen with SARS-CoV-2, probably also impacts you for influenza. But here we'll be talking about how pre-existing immunity is going to shape or affect your disease status or somebody's disease status when they're infected. Next slide. So here we have a challenge study. Actually, it's a review of challenge studies that was published in 2008. And here they're looking at how illness is related to pre-existing H3 and 2 immunity. So when people get infected, what's the likelihood of them getting sick, depending on their levels of antibodies. And what we see is people at low titers, so less than 1 to 12 or between 1 to 12 and 1 to 24, about half of individuals when they get infected are getting ill. However, when we look at people with higher titers, a lot of people actually don't get ill because of those higher titers. Next slide, please. So pre-existing immunity affects whether or not you get disease when you get infected, right? And it actually also impacts the duration of your illness and probably and certainly the duration of shedding, but possibly the duration of transmissibility as well. So here we are looking at hemagglutinin inhibition antibodies, again, on the left-hand side, so in panels A and D, and then neuraminidase antibodies in C and F. And if we look at A and C, it's a little easier with a pointer, I apologize. So shed time is shortest in kind of the purple and blue colors, and it's increasing, going from 1 day up to 12 days as you go down to yellow, right? And what you can see when you look at these bar graphs, for example, looking at the first one in panel A, is that the individuals that shed for a really long time, so kind of those green and yellow colors, are really concentrated in the bottom left-hand corner, which are the individuals that have the lowest antibody titers. And we see that across adults and children, indicating that your level of antibodies, if you do get infected, is going to determine how long you're shedding virus for, right? And we see that down in D and F when we compare people at various antibody levels and look at the duration of shedding. Once again, the line is kind of equal to 1, so they would be equal. If anything above the line is longer shedding, anything below the line is shorter shedding. And what you can see is for both HAI titers and neuraminidase titers, there seems to be kind of a threshold effect overall, where people at higher titers are likely to shed for significantly shorter periods of time. And in adults, for neuraminidase titers, we see a kind of dose response where individuals are shedding for a shorter period of time as their neuraminidase titers increase. Looking on the right-hand side over here at looking at the duration of influenza-like illness or cough, so the duration of illness, we also see that neuraminidase antibodies are protecting for illness duration if you do get sick and develop symptoms. All right, so Antibodies are protecting us from getting infected in the first place. They protect us from getting disease. And if we do get sick, they decrease the duration of illness. So of course, if you get infected and you don't have symptoms, you're not going to go into the physician to be counted. Also, the shorter time period that you're sick, the less likely you are to go into the medical system. Next slide, please. So the question is, do antibodies also impact the severity of disease if you're infected? And the short answer to that is yes. There's data for both adults here. This is vaccine immunity, looking at the odds of both hospitalization and being admitted to the ICU. And pre-existing immunity does impact your probability of getting severely ill. It's going to reduce the probability. Next slide, please. And we see the same thing in children, and this is looking at influenza-associated deaths, right? So pre-existing immunity is going to, even if the vaccine, and so some of these years were years where the vaccine didn't work particularly well, but even if it doesn't prevent infection, it has been shown to prevent more severe illness and death. Next slide, please. Okay, so lower immunity not only impacts the number of infections we're going to see, but may also result in increases in the number of medically attended cases amongst those infections and in increased severity of those cases. Next slide, please. So the question comes up, well, what about influenza vaccines, right? We didn't have infection last year, but a lot of people went out and got vaccinated. Unfortunately, we haven't seen vaccine effectiveness from one year to the next, meaning that it's usually only affects that season. Next slide, please. And even within a season, as Dr. Meyers had already mentioned, vaccine effectiveness can be suboptimal, right? In the last 5 influenza seasons, vaccine effectiveness has not crossed 50% for influenza. And this is looking just at infection, not severity of disease. And the other issue is that vaccine uptake in the United States and globally tends not to be very high. In the US, it's generally been between 40 and 60% over the last 10 years. Next slide, please. So there are a lot of reasons to think that the flu season may be particularly bad this year, right? We've got that increase in the number of susceptibles. So that'll increase the number of infections that occur in the population, but also for people who get infected, because their level of pre-existing immunity is likely to be lower. We do expect to see an increase in disease severity, including severe cases. But there are a lot of unknowns that will affect what the influenza season looks like in 21-22, right? The extent of social distancing and mask usage is unclear. We don't know, as Dr. Meyers covered, we don't know what influenza strains are going to circulate. And we really don't know what vaccine uptake and effectiveness is going to look like. There's less data. It may be a very good match because there was less genetic diversity, but there was also less data on which to make a choice of what went into the vaccine. And you've got a lot of people who went out and got vaccinated last year who may be thinking, you know what, I went out and got vaccinated, there wasn't any flu, I don't know if it's a worthwhile thing to do this year. So really remains an open question. Next slide, please. But we can look to RSV at least a bit to kind of project what may happen. So this is RSV in the United States. We've seen similar things happen in other countries. We certainly got an early warning from Australia. RSV is now circulating at high levels, or has been in several states. It is filling up pediatric ICUs, right? And it's actually circulating off season. So RSV, like flu, we didn't see any RSV in the United States, or very little, at least for a prolonged period of time. Once the rates of COVID kind of decreased in May and June, we saw this huge increase in the number of reports of RSV cases in the United States. And so I think that, that indicates to us that we've got these same things going on, right? You have this buildup of susceptible individuals. And in this case, it's probably causing some off-season RSV transmission and an off-season peak. Next slide. turn it over to the ChemBio folks.
Thank you so much, Dr. Gordon. Now we're going to pass it over to Chuck Caso, who is the Vice President of Sales and Marketing at ChemBio.
Thank you, Robin, and thank you to our presenters, Dr. Lauren Meyers and Dr. Aubree Gordon. Both presentations provided strong support for being prepared for the upcoming flu season, and one that will likely run in parallel with COVID outbreaks, which we all know has many of the same symptoms as the flu. To that point, ChemBio does offer a product to differentiate flu and COVID at the point of care and allow for immediate patient management. As you can see from the slide, our status test offers excellent performance, requires no instrumentation, and we do currently have available inventory for immediate purchase. Please contact us at www.chembio.com for immediate details. In closing, I'd like to thank all of our frontline workers, the NACCHO organization for hosting the webinar, and again, to our presenters. It has been our pleasure to sponsor this educational event. I believe now we are going to open up the lines for Q&A. Robin, I'll turn that back over to you. Thank you, everyone.
Thank you so much. The floor is now open to ask questions or share any specific needs or requests you have as you respond to COVID-19 and influenza this season. As a reminder, please use the Q&A feature to submit your questions. And while we wait for questions to be submitted, we did have a few sent in prior to the webinar. So I'll just go ahead and kick it off and ask our panelists. Given the spike we've seen in other respiratory infections, such as RSV, I think we've touched on this a bit, but what do you predict the flu season will look like? And maybe more specifically, how do you anticipate COVID will impact the severity of the flu season this year?
I think, well, Dr. Gordon sort of ended with a graph showing what RSV is indicating for us, that, we may see a large and early surge in influenza. But as I think we both have highlighted, it depends on all these things we're not sure about, the evolution of the virus, the match with the vaccine. I'm talking about influenza. But importantly, and what we've seen throughout COVID, is what happens in our communities absolutely depends on policy and behavior. And so the biggest impact COVID is going to have on influenza is in leading to policies and behavioral changes that change opportunities for transmission. So if we, in communities that are seeing large COVID surges, seeing strains in their healthcare systems, if they respond by issuing face mask orders, closing restaurants, sending kids home from school, then those will break chains of transmission for influenza as well. And so I think that the direct or the impacts of COVID on influenza are going to be through the intermediate step of COVID leading to interventions that impact flu transmission, just like we saw last season.
Thank you. That also answered one of our other questions about how the COVID mitigating factors may continue to suppress flu for the 2021-2022 season.
Yeah. And I will just actually add one thing. One important difference I think between this year and last year is that last year in a lot of communities, kids really did not go back to school for a while in the fall. And when they did, there were a lot of precautions put in place, including face masking, strict quarantine isolation policies upon detection of cases. And I think that's one thing, at least for now, that looks like it's going to play out differently this year. And kids are really sort of amplifiers, play key roles in the transmission cycle for influenza. So, even if we do enact community policies to slow COVID, the situation in schools may just look different than last year and sort of lead to a worse flu season, or a flu season this year in a way that we didn't see last year.
Thank you. I think that leads nicely into a question we have for ChemBio. When we talk about testing on a weekly or daily basis, especially as kids return to school, is ChemBio able to provide this number of testing kits? And have you seen an uptick in ordering of these testing kits?
We have, I think for lots of the reasons that Aubree and Lauren described, clinicians, physician practices, hospitals are preparing and stocking up, for flu and COVID together. In terms of testing in a school environment, unless it's in a nurse's office that has a CLIA waive license, I don't know that this test wouldn't necessarily be used in an asymptomatic population. It's really designed for somebody that has symptoms and you're trying to differentiate between flu and COVID. But certainly we are seeing an uptick in orders. We certainly anticipate, that to only increase, and we'll certainly be fully prepared for that. As we go into the latter parts of August into September, and when or if we begin to see the first cases of flu and the press starts to grab a hold of that relative to hospitalizations and strain on the healthcare system that Lauren described, then we'll probably see even more orders for that. But right now we are beginning to see clinicians order the product, yes.
Great, thank you. This would be a question maybe for Dr. Gordon and Dr. Meyers. What kind of messaging strategies would you use to communicate the simultaneous need to vaccinate for COVID-19 and the flu?
I think I would use communication strategies that are, really stressing some of the risks of influenza. I think, and the risk of a kind of a twin-demic, which we heard a lot about last year. I would worry a little bit about using those words just because they were used last year, and I think it did push some extra people to go out and get vaccinated. I think the other thing is when you look at risk to the pediatric population, particularly to children under 12, we don't have a COVID vaccine available for them, but we do have a flu vaccine available for them. And when you look at the number of deaths in the United States compared to the estimates for past flu seasons, in those age groups, they're actually quite similar. So children are really at, and maybe even higher, in fact, in some of the years. And so children are really at a huge risk from influenza. And so we can, encourage people to go out, get your flu vaccine, try to reduce the chances of that, leading to school closures. And also, I think last year, one thing that worked for individuals was also kind of highlighting the fact that if you don't worry about, if you don't have to worry as much about getting influenza, then that might reduce the risks of scares as well, for kind of thinking that you might have COVID.
Great, thank you. Another question we have, which I think you can both speak to very well, is immunity from actually having the flu the same or similar to having a flu vaccination, or immunity from a flu vaccination?
I guess I will speak to that. So for the flu vaccine, it's really, so I talked about a little bit about hemagglutinin and hemagglutinin inhibition antibodies. So if you think about that as like that surface protein, right? The flu vaccine is really designed to generate antibodies to a particular region of the hemagglutinin protein, that glycoprotein. Whereas with, you do generate some other antibodies and some other immunity, but with natural infection, you get more of a T cell response. You get more response to neuraminidase and other internal proteins. And flu vaccination, that tends to last, the effect of that, the protectiveness only lasts for one season. I talked a little bit about what we see for natural infection, and that 2015-18 season, if you remember, that was an odds ratio of 0.18. That was significant. So over a 3-year time period, we saw that would be a vaccine protectiveness of about 82%, right? So the protection that you get from infection certainly lasts longer and is probably a bit broader than what we see from the vaccine. However, there's also risk with natural infection. So I would encourage everybody to go out and get vaccinated.
Thank you. We have a couple questions for ChemBio. Is the dual test FDA approved?
It's EUA, so it has been reviewed by the FDA. There is an FDA EUA associated with the product. It is available for sale in the United States. Yes.
Thank you. And then we have a question. Do we have any idea of how many COVID influenza co-infections have occurred in the US, maybe over the last year? We saw a lot of providers test for one virus or the other, but not both.
I haven't seen any recent reports or data on that, but just given the fact that there was so little influenza in the US, until recently, the numbers are probably very, very low. The naive calculation you would make is the chance that someone was co-infected is sort of the chance that they were infected by one times the chance they were infected by the other. And the chance they were infected by influenza was almost zero. So, and of course there's more complexity than that, but I think this season will really be an opportunity to see if there is any sort of interaction. I mean, certainly there may be some behavioral correlates. If somebody is out engaging in activities that make them exposed to infection, they may be more likely to encounter both influenza and COVID, but there may also be some biological interactions that we're not yet aware of.
Thank you. I think we've already discussed a bit about the protection from the T cells versus the white blood cells versus the antibodies. Could you speak maybe, I know you both touched on this in your presentations, but could you speak to how COVID testing and the non-pharmaceutical interventions impacted flu testing and numbers last year, and whether you anticipate kind of COVID impacting the flu season this year, and whether that might impact the testing and the flu vaccination numbers?
I can't really speak directly to sort of the behavior around flu testing last year. I do think that testing has become much more familiar to people. I mean, you probably know people, or maybe you yourself have had an exposure where you end up testing yourself using a store-bought kit, multiple times. And so I think testing is something that is becoming more commonplace, more kind of the norm in navigating the changing risks in our communities. So I would not be surprised if that sort of translates to more of an appetite or demand for testing for influenza along with COVID, as people try to understand what their situation is, what their risks are to their family and others around them. But that's just a hypothesis at this point.
And Robin, if I could add to Dr. Myers's comment, I think that she's absolutely correct that testing has become much more familiar to the broader citizens in the U.S. But I will say, from a personal experience, I did have some symptoms last year that were flu-like or COVID-like, and the only thing I got tested for was COVID. So I do think there was a certain amount of COVID centricity that folks didn't really test, even though the symptoms were there for flu. Now that maybe that was just unique to the location that I went. I hope so. But I think that's why we do have to be prepared for both, and why practitioners need to be thinking about both when they're testing, because there is antiviral therapies that are available that would lessen symptoms for flu. So you've got to differentiate between the two.
Thank you very much for that. I think that was a great, concise way to wrap up, as I'm aware of the time. So I want to thank our speakers again, and I want to thank everyone that was able to join, and for all the work that you continue to do every day in the field. We hope the information provided today will help you all as you prepare and plan for the upcoming flu season. Our webinar is going to wrap up right now, and we will follow up with the recording in an email. So thank you all.
Thank you.